for joining us this Sunday evening. It's our extreme pleasure and privilege to conceptualize and organize such rewarding initiative for organizations, companies, CSR arms, and other new social businesses, startups, and individuals engaged in such remarkable, sustainable, scalable, responsible work for humanity and uplifting communities and societies. In the last 3 years, starting from 2017, we have made a mark by successfully hosting three ground events, felicitated more than 180 leading corporates, businesses, social organizations, and individuals for their CSR and social initiatives with the help of and the guidance of renowned dignitaries and jury members and prominent organizations as our supporters and partners. We are truly honored and thank them for their most valuable support for this initiative and to the Council. Now, while the world has entered into a year of health hazards, economy, and social uncertainties due to COVID-19 pandemic, we as a health and well-being institution in India have become more firm and responsible in our ideology to promote health for all, engage more entities working towards uplifting communities, societies, and the needy, and try to support the government initiatives of health and environment for our countrymen. Therefore, we felt the need for continuing our fourth edition of the CSR Health Impact Awards 2020 with a focus on highlighting the contribution of organizations and individuals fighting COVID-19 and also the noticeable achievements in the main CSR category. This year, just like our other landmark web initiatives, which make us the leading institution in India to host many web-based initiatives and reach out to millions through our live streaming and online promotion, we will be hosting the fourth CSR Health Impact Awards 2020 COVID edition as a special web show on the 21st and the 22nd of August. Now, in this special edition of the pre-event show today, we have selected some of the key social projects out of the 230 nominations received, and we feel that it is important to highlight such influential initiatives which have a capacity to transform community and society at large and create a sizable impact. Today, in the CSR Impact Show, we have project teams and key people behind these influential initiatives. And we bring you one-on-one with the team and the individuals to understand the vision behind such initiatives and how they have made a mark in creating such a remarkable impact. We will welcome today and speak with the teams. The teams that we have today include Artist, Wish Foundation, American Indian Foundation, Vedanta Limited, BRSC Welcome Cure, and Mantra for Services. I would like to welcome all the team participants today, and I'd like to start and welcome Dr. Hima Divakar, the founder of Artist. Welcome, Dr. Divakar.
Namaskar.
Now, the Artist project that we're going to talk about today is Capacity Building, Preparing COVID Warriors. Now, the Artist team, led by Dr. Hima Divakar, has spearheaded training healthcare professionals in maternal and child health space on a large scale through a digital platform. This has empowered frontline health providers to reset and restart their work with confidence and competence. Ma'am, thank you so much for joining us. Want to understand from you, is it just COVID that made you go digital?
I love this question, Anisha. Thank you. And thank you to the IHW Council because in the last 3 years, when we have scaled up our attempts to reach every girl, every woman, also generate the demand, giving them awareness, generate the supply side by building the capacity of healthcare providers. We used to travel nook and corners of the country, like right from Aligarh to, the Girid or Sitapur or Tumkur. And then I said, oh, this is getting impossible. This is not the way and we cannot fulfill our dream. And that is why 3 years ago, I decided digital is the only way. And we embarked on a major digital connect initiative, and look back with satisfaction of a lot more things we can do. But believe me, Anisha, there was just nobody who was convinced that this could ever fulfill the gap of the implementation of many of our initiative. And I must thank COVID pandemic for coming to our rescue, if I may say, because what we could not do in the 3 years of our digitalization attempts to reach people, just in flat 3 months, everybody came on board because they said, yes, we agree that that's the way to move ahead. So before COVID, during COVID, and definitely with the Prime Minister announcing the digital mission, beyond COVID, we will go digital, because I always believe that the digital technology and healthcare should be strongly married to each other for a blended benefit to all.
Definitely. In our country, the size, the scale, the population, you can't reach everybody by physically going there, right? And like the Prime Minister also said, digital is the way to go. But what is the vision and the mission of artists?
Well, I'm working in the women's healthcare space as an OBGYN since the last 3+ decades. And my vision is in alignment to change the healthcare ecosystem, prevent illness, and promote wellness. So this is what we announced about 10 years ago. And again, I allude to the fact that COVID has brought into the forefront that health is wealth and prevention is better than cure. That definitely has re-emphasized our vision of preventive healthcare, and the mission, of course, through artist, the art of artist, ART. A is for advocacy. We have to tell people, make them aware of what's going on. And the R is the research, because Indian context is very different. What is going on the ground, what is feasible, what we can and what we cannot, how we reshape our implementation initiatives to make things work in this great diverse country. That is the R, the research part of it. And the T is the training and capacity building, which we've already said. So the training part of it, that is the blended both digital and in-person component, and by generating the supply side as well, the ART, the advocacy, research and training. Actually, the artist expands into Asian Research and Training Institute of Skill Transfer, which is based out of Bangalore. So from about a decade, we have recognized that India should be the role model for the whole of Asia. That is why when we launched this, we made it the Asian Research, because many a times from our organization of the gynecologists, whatever has worked for us in India, Nepal, Bangladesh, inclusive of Pakistan, Maldives, everybody wants to kind of capture that prototype or the model. So we should really be in the forefront of setting our pace and stage for Asia. So that is, in short, the vision and mission of artists. Yes.
Definitely. It's always easier to copy, paste, replicate and start something on your own. But you said that COVID has hastened digital awareness, and people have understood that prevention is better than taking reactive measures to getting a disease. But given the status of women in our country, they never go to a doctor unless they are in a severe problem. So how are you tying in this awareness, and how are you training healthcare people to make end users, the women, be aware of their health and take preventive steps? Because most women think, unless it's really bad, I'm okay. How do we get this out? And is this entire pandemic also making women aware that whatever small issues, let's be more aware and let's reach out to people, because now it's easier. You can do it digitally.
On one hand, Anisha, I must say that it's not only women in India, but the entire community of us has a mindset. Okay, when we get into trouble, let's see, we'll cross the bridge when we come to it, kind of. The preventive care, both for men and women, the mindset has to change. And this is a compelling moment where this change can be bought in, and it should be bought in for sure, for the entire community, may it be women or men. Having said this, the gender inequalities, the empowerment of the women, the education of the women, the equal opportunities to access care and make her own decisions, there is a huge gap there. So there I agree that women may have wanted to do this, that and the other, but there are many, many more constraints than a man would have to reach the same amount or degree of, avail the same degree of preventive care. Having said this, the new generation, we definitely want to integrate the sustainable development goals in a way that education, gender equity, empowerment, good health for all, everything we should break the silos and integrate that. So even in the pandemic of COVID, we have again focused on the ART, the advocacy, that is the preventive care, which comes in so many channels on the television, radios, of which I have been an integral part. But the kind of initiatives on the social media, on an interactive session where the women and children, they can ask us questions. We have done a whole range of program, right from the school children who ask some brilliant questions on the preventive methodologies and what if and this, that and the other. And we see the younger girls taking charge of themselves and the women taking charge of the families to do their best bit in this pandemic. So advocacy has been, one great part in the COVID initiative. And as soon as we recognize that our state of Karnataka, the COVID is coming, because we can have a predictive model and say when we will reach the peak. So double quick readiness is the key. So we got the digital platform onto every single district pan Karnataka in collaboration with the Rajiv Gandhi University of Health Sciences, made an interactive module, the videos, and they had to implement it, send us back the photographs to see how. So entire preparedness of the healthcare workforce, half of them who had run away to their hometowns, they got the confidence to come back and follow the protocols, as it were. So the demand and the supply, both we have to match all the time, that we have to keep it in focus. And the research part of it, yes, we've already produced 3 papers in the international journals, because they're hungry for the Asian data, hungry for Indian data, because our numbers of cases are so many, and our women behave a little differently, being asymptomatic, and as you said, not seeking care on time, and what can be the implication both on her and the child. So there's really a lot happening in the COVID pandemic, and we are learning more lessons each minute, I must say.
Right. Dr. Devata, you've talked to us about the advocacy part, but I still want to understand how the initiative worked out, the initiative undertaken by artists in this COVID pandemic, because no one knew it's coming, right? And people are taking it easy, going digital. And you said people just ran back home after they heard, oh, pandemic is coming. So how did you take your digital platform all over the state of Karnataka?
Yeah, so as I said, the advocacy for both the peer group, that is the OBGYN group, to sensitize them about the newer protocols that they will have to follow, both for the care of the mother and the child. That was one part of it. The advocacy for the staff of the hospital, who have to fall in line with the infection prevention control policies, and everything was like a live demo, because skill transfer is a skill transfer. In theory, everybody will know, but is it getting implemented on the ground? That gap has to definitely be bridged to see the impact. And even the housekeeping staff and the security, right from there, the entire group of the hospital cadre, inclusive of the front desk, the admin staff, the courses ran for every segment, because it's important to break the chain of COVID. We should maintain a continuum of the chain of our healthcare providers, doing the same things, being on the same page, no mask, no entry. There's some simple, dictums like that, which made them fall in line. And every week they had to send us some videos and photographs of what they've actually been doing in their own setups, because we have to make sure that they have implemented what we have skill transferred. So that was about the healthcare community. Even every day new information about what kind of tests we should be doing and how we have to care for the pregnant women, because everything can stop in a pandemic, right? But menstruation and deliveries cannot stop because they have to, anyway, by nature, have to happen. So this is hugely challenging because it becomes an essential service. So the capacity building was one part of it, but at the same time, each one teach one is the kind of policy where every segment, wherever we could reach, whether it was apartment complexes, corporates which are sitting at home, being clouded with many of the doubts and anxieties, we had interactive sessions for each one of them to tell them why they have to do whatever they have to do. Because just telling them do this, that, and the other, there's a little more to it. When we dialogue and interact, they come out with some strange doubts. And once they are convinced, then they know that they're responsible not only for their health, but also for the health of the others around them. So that makes them a little more alert. At the end of our dialogue, I will show you a 2-minute video about how we did the digital courses, actually demonstrating the donning and doffing of the preventive protective equipment and hand washing, and came out with some acronyms to made a song to let them recall that again and again. So whatever, because it's innovation to implementation, right? Because this is it is so little we know about this, but there is so much that we need to do. So that was a challenge, but where there's a will, there is a way.
Dr. Divakar, can you briefly tell us what is the feedback that you have received from people about this training program? And does the knowledge of, I'm doing my best and this is the best precaution that can be taken, has it been empowering for these people? Have they overcome their fears, and are they able to better deliver the services that they're supposed to?
Certainly. I think, that's why we said the confidence and the competence, because only when they understand and then they actually done it, and there's an opportunity to, strike back with us for any kind of queries or barriers or challenges that they may have had, that makes a huge difference. And also Health Arch is one of the apps that we have introduced in collaboration with Mount Sinai Hospital from the New York City, where many thousands in the community get preventive healthcare messages, the mindfulness courses, and they can chat with the back-end team of the doctors to solve. And then the entire home monitoring system is available on the app. So those who are at home, especially with diabetes and hypertension and other comorbidities, who need a day-to-day kind of a monitoring. So that is also on the digital platform made available. And Health for Her is a YouTube channel, both in national language and English and Kannada as well. So the scale up has already happened, because this initiative which we piloted in the whole of Karnataka to the teams of the healthcare providers, it has now reached Madhya Pradesh, Rajasthan, Maharashtra, Jharkhand, UP, and some of the other clusters in Tamil Nadu who have sought similar kind of digital training programs. We have created the master trainers and cascading it, because I already told you the scale that needs to be reached is so big that one person cannot really do it. Of course, I have Dr. Divakar and the whole team of artists, but there are so many more escalating this implementation initiative everywhere in the country. And now we are doing the trainings for Myanmar and Bangladesh as well. So, everybody feels that it's easy to access, and that's a great change in the mindset. And there is an opportunity for us to do our bit beyond the geographies of where we are located.
Great. Ma'am, what is the roadmap? What is the plan ahead for the future? What's the new normal and beyond?
The new normal, Anisha, has already become like old, because like we've all got, acclimatized to it, and, the human nature of, we have to live with it, so adapt it, but see the positives in it, like how it has brought so many of the stakeholders close to each other, to work in synergies, to escalate the vision and the mission. And the roadmap is, and has always been, we strongly believe that women's health is nation's wealth, because it all, if you actually see the complexities of all the diseases which are now prevailing in the adults, it all starts in uterus. Because if you invest largely on the care of the pregnant women, the child in the womb which is programmed appropriately if she is healthy, and from there begins the healthy generation next. So in keeping with our philosophy of connect and collaborate, we are happily connecting with all this relevant stakeholders, because it is not one compartment that you have to look at. We have to integrate, just like the IHW philosophy when they say good air, good food, good health, good everything. So there are so many elements, so many aspects to it, and we have to come together to make this world a better place. So in the roadmap, we will move along ART, that is advocacy, research and training, because unless you research, document, audit the data, you have to make course corrections. You have to learn your own lessons to change gears and see how best and how far you can reach. So the journey is long, but something has been done, and we humbly submit that a lot more needs to be done. So the mission is on.
Thank you so much, Dr. Divakar, for taking us through your project and how Artists is changing lives and training people to deal with the new reality. I would request you to please play out your video so that all of us can have a better understanding of how this training program is prepared.
Sure. Thank you, Anisha. Yeah.
Welcome everyone yet again this fine morning to learn more about how to make your hospitals a COVID-friendly hospital. We are so happy to have 26 hospitals on board today to learn more from us about the 3 important issues. We are recapping what we have taught you 4 days ago. One is about the social distancing, which is a must in your waiting rooms. If you've not already set it, please keep
Bijapur, Bagalkot, everywhere. And then we have to actually demonstrate this is how you have to make the patient sit at a distance of more than 3 feet, and how they have to enter, how the security guy has to handle them. And then for hand wash, we had a small acronym called SUMAN. So we said, oh, you'll be having a girlfriend called Suman. So remember her, Sida, Ulta, then M for Mutti, N for nails, and A for Anguta. And, we used to teach them in a way that the appropriate method of hand washing is also followed, and the last of it, the Kalai. So when we say 20 seconds of hand washing, then it should include all of these steps, the correct way of hand washing, which was demonstrated, and we made them repeat that. And week after week, the teams happily sent us the videos of what they're doing and how they, and a whole process of donning and doffing the PPE. This is indeed a multi-step process, which in itself will take a complete 5 minutes. So how the staff nurses and the healthcare providers have to wear the goggles, because just beware of the men is what we say, MEN. Mouth, eyes, and nose. That needs to be covered. So MEN for mouth, eyes, and nose, which should not be repeatedly touched. That's the importance of hand washing. You repeatedly wash your hands so that the virus cannot enter even if you touch your nose or mouth or eyes. That is the usual portals of entry, and how you need to wash your hands after this, how you have to wear your mask, and how you have to wear your gown, and how you have to wear the gloves, and how you de-glove, and all the way through. So every step of whatever they were supposed to do, inclusive of conducting a safe delivery and the care of the child. So this was a very interactive module with very many interruptions and dialogues and whatever they want. how many ever times they want, they would ask, they would make sure that they know. And I used to always tell them, the air hostess in every flight tells you about the oxygen mask dropping, etc., etc. But when there is a real crisis, unless you've done it once before, you may not be able to replicate what she says. So they have to actually do and show, and that is the essence of skill transfer. So I think it has been a very insightful and meaningful exercise pan-India now, and this will continue to some clinical standards of safe delivery and childbirth and other aspects for women and child care as well. So this has inspired us and motivated us definitely to do more. And as you said, what needs to be seen is from innovation to implementation to make an impact. And we are well on the road to be doing that.
Thank you, Dr. Diwakar, for showing us this video, and wish you all the very best in your mission to transfer relevant, important, crucial skills by all means possible, real contact, digital contact. We wish you all the very best.
Thank you very much. On behalf of Diwakar, myself and Team Artist, Namaskar once again.
Thank you, ma'am. The next team in the spotlight is Team Wish Foundation. Their project, LEHS COVID-19 Program Outreach, uses a digital platform to provide teleconsultation to home quarantine isolated patients. Plus, it also helps in tracing and tracking of the contacts, plus the continuity of care through telehealth OPDs to communities during COVID-19 pandemic. Project LEHS COVID-19 Program Outreach has helped in building capacity of healthcare services providers within facilities on COVID-19 protection, prevention, and curative needs. From the Wish Foundation team, we have joining us now Mr. Rajesh Ranjan Singh, the Chief Executive Officer, Ms. Alka Singhal Pathak, Senior Advisor, Program Management and Development, Joy Gopal Poddar, Head Business Development, Mr. Ramashankar, Specialist Health System Strengthening, and Syed Arish Mahmood Ahmed, the Project Director, HWCI. I would like to welcome all the Wish Foundation members for joining us on this CSR Impact pre-show. Mr. Singh, let me start with you first. Tell us about the program that you have come out with, the digital platform for teleconsultation. Was this an existing program or did you develop it new? Talk to us about this program.
Thank you, Anisha. Very good afternoon to everyone, and especially to you. Absolutely, I think the telemedicine program that Wish really developed, it was developed around 2.5, 3 years back, and this was developed in the context of the philosophy that we have, that if we can really bring the healthcare closer to the community, and what best then the digital can really bring that to the homes of the community members there. We developed this concept around 3 years back. The concept was basically piloted in a sub-center in extreme rural areas of Rajasthan. And the first 10 sub-centers gave us a very good result. And later that got scaled to around 65 across Assam, Rajasthan, MP, Uttar Pradesh there. The model of this basically was that there was already a discussion going on in the country about transforming the whole sub-center into the primary health, into the health and wellness center. And later, after 6 months or so, the Prime Minister also really spoke about this. And in fact, the country, he said that all 150,000 sub-centers will be converted into a health and wellness center. However, we all know that we have a lack of human resources, lack of supplies. Almost in some of the extreme rural areas, the human resources doesn't really, stay there. The transportation issues there. And what we really found is that I think one thing that can really make a difference is that if we bring the digital to these sub-centers, it will really address the issue of 3A, which is accessibility, availability, and the affordability. Just as having this digital health platform, your services are accessible. You can really run it even in the evening hours, and some of our centers are running until 8 p.m. in the evening hours there. Then your services are available always. It's accessibility doesn't mean that you have the services available, because your consults are going on, your tests are happening, so that's availability part. And affordability part is that it's really costs negligible amount, that one doctor can really treat in a day roughly around, say, 100 patients or 110 patients there. And you can really quickly really do the mathematics of that. So this really helped us in addressing. It also helped us in dealing with the issue of the testing part. You can have a doctor in the primary health centers, but most of these primary health centers doesn't have the test or testing facility there. So the whole questions of accessibility, availability, doesn't get fully addressed if you really bring the test again along with these consults. And our health and wellness center or digital telemedicine centers actually have been able to address, and we really, with the technology platform, our digital health team align the consult with the vitals also. So as the client enters, client will get all the vitals over the Bluetooth there. So he doesn't have to really touch everything like, physically there. And the test happens physically, but the result goes to the doctor who's sitting 1,000 or 2,000 miles away from there, right? In a fraction of seconds, he or she, the doctor, sees everything available on the screen and accordingly really advise it. This model not only help us in dealing with the general ailments, but also around 5 to 6 elements. And our colleague Arish can really talk more on that. Specialized services we were able to really observe. Gynae is one, pediatric is second, some of the non-communicable diseases third, geriatric was fourth, mental was fifth. So around 6 or 7 specialized diseases were also treated through our intervention. And as a matter of fact, the intervention was really liked by different state government, and some of the state government asked, advise us to help either scaling from the government resources, or requested us to really scale it from our own resources. So the government is also very open to adopt this kind of model with a certain level of kind of flexibility inbuilt into it. And hence, if you really see, this has been a successful model. Coming back to the COVID, Anisha, if you really see this, no touch, no see kind of model was quite apt and appropriate when the COVID came in. And we suddenly saw a spike in the consults there. We realized that the primary health centers were close to around 6 weeks, because the advisory was given. Most of the health center staff were, aligned for, surveillance and survey, home-to-home survey there. But this telemedicine allow us to really continue providing those kinds of services to the last mile there.
Right. Ma'am, I'd like to come to Ms. Alka Singhal. Ma'am, can you tell us how this telemedicine and teleconsultation platform adopted to the COVID era? Because like Rajesh ji told us that, tests are physical. They have to be done physically. The reports go to the doctor, and, you don't have to physically meet the doctor to get your results. But when it comes to COVID, testing facilities were rather constrained initially. What was it like? How has this consultation platform adopted to the COVID scenario, and if people have a requirement for COVID treatment and management?
Alkaji, you're mute. Alkaji, you're mute.
Maybe Arish, you can take up this just to save the time.
I think ma'am is starting.
Arish, please take it up. Yeah, I'll join him. Yeah.
Yeah, Anisha, to be very True. I think for us, we had different hub and spoke models that were already existent while we are doing the telehealth solution. Now, once a patient reaches a hub or through a facility of getting into a teleconsultation, fortunately for us, the doctor is having an AV consultation. It is not just an audio consultation. The doctor is also able to see the patient and seek a lot of queries in terms of the symptoms, the factors that are affecting the patient and the beneficiary. At the same time, the doctor, because the patient is, if the patient is there at the facility, there are a lot of medtech products which are point of care devices, which also helps the doctor to understand the vitals, the situation and condition pertinent to the symptom of the patient. Now, once all this data is there with the doctor comes with a provisional diagnosis. Based on the criticality and the gravity of the symptoms, there is also a decision support system available for the doctor for a triage referral. Now, within the platform, we had also grid mapped the primary healthcare centers, the community healthcare centers, and the other hospitals that a person can be referred to as a part of the grid. And accordingly, based on the COVID scenario situation and the symptom, an appropriate triage was happening. So this not only in terms of, I would say, the beneficiary benefit, also a triage referral was reducing the workload on the secondary and tertiary sector, and at the same time the doctor were able to support the beneficiary with appropriate provisional diagnosis and cure. So I think this was very important, and the moment we saw the criticality and gravity of a symptom which was very much near or aligned to COVID, there was a very specific referral based on the government guidelines that was happening, and this has been one of the critical efforts leading to triaging, leading to effective cure and continuity of cure, like Rajesh sir was saying, during the COVID-19 pandemic.
Right. We also have Mr. Ramashankar, the specialist in this project. He is the health system strengthening specialist. Mr. Ramashankar, were there any glitches? Were there any problems faced during the COVID time? Because, the doctors have been very stretched. I know of psychiatrists having to, attend to two COVID patients because the other doctors are sick, or they are unavailable. So it's one thing that you have the demand side managed with people coming in with the issues. What about the supply side? Were there any issues there?
Yeah, just hi everyone. A very good afternoon to all of you. So, as you know, the COVID-19 is an unprecedented pandemic. So, unprecedented action was also required. And as you know, the global world was overstretched. All the health system was, overstretched. So definitely in the initial days, we had lots of problems, and but the government taking immediate measures of continuous lockdown, and by the time all the facilities, so the district hospitals and the CHCs and the PSCs were all ready, all the doctors were trained, and what we did, we from the day one, we started capacity building of all the healthcare providers, so that we train them, we equip them, so that they can take their precaution first of all, and then they can communicate the same messages in the community. Just to give you an example and how digital health has helped us in that, I'll just give you a few of the examples. As of date till, Wish has almost seen along 5.57 million people, either through teleconsults or through community surveys, and out of that we were able to find 0.6 million people found to be influenza-like illness. So those were accordingly taken as per the guidelines of Government of India. In MP, just to emphasize, just because of the already overstretched system, we had this telemedicine unit set up there, and home management, telecall was made, and home management was done directly from the telemedicine unit. So that definitely helped us. And coming back to the capacity building, as I said, that goes on a consistent basis. Why I say that? Because as you know, the guidelines are getting changing every time. So we have ensured that more than 20,000 people have been trained, and we have a self-learning module we have launched where on a concurrent basis, the guidelines are updated, and all our healthcare providers are getting equipped with the latest guideline. Now, coming to that community angle, the community angle, that has been also taken care of by us. So if I just give a small example of Rajasthan, almost 8 lakh, means households we surveyed, and almost 4 million people we just checked. And we found somebody of influenza like illness, and actions was taken. So the risk communication and community engagement was also one of the most important strategy, because see, the overall health system has been stretched. So you have to have a multi-pronged strategy, right from digital health initiatives, capacity building, risk communication, community engagement, followed by IEC and VCC.
All right. To Rajesh ji, I want to ask that how are you generating data for the government? Because this would help the government as well, since you have such a large outreach across the depths of India. How are you generating evidence for policy action through what you have learned in the management of COVID-19 from your platform?
Well, I think all these platform, and Dr. Ramashankar really mentioned that, because we are a technical support partner for various state governments there, and we have a responsibility as being a technical support partners also to really manage and mine the data on behalf of the government there. What we have done over a period of time, so this whole classic example of telemedicine that Arish and I spoke about, it has a real-time data analytics there. The triaging happens like real time. You don't really. So the whole backend platform has been created by the team, including Arish and his team, and the digital health team members are there. That for every level, we have a dashboards there, which really helps them on a real-time decision making. So the data, what comes to my desk, data that goes to the deputy director of NHM of the state, or data which goes to the mission director level, who is the actual, he or she gets the data of that level, which helps us in taking the decision quickly. The data which comes to me is of a different level, and the data that goes to the deputy director of state, which is from the state government, is completely of a different level and types also. My data is more operational and strategic, whereas for the decision maker, which is mission director, it will be completely strategic and top line kind of data there. What we have done over a period of time is that we have also learned how to really develop the impact measurement framework. So tracking the various indicators, and we studied around over 1,200 indicators, global indicators, and we really cull that out because our domain is primary health. What can really be apt, appropriate, and will work within the primary health domain. And out of that, around 256 data sets we really capture on a real-time basis currently. And those are data sets which are more macro in line. Within that, there are around n number of subsets there, which are more for the managers, the coordinators, who are really taking care of a district or of a state or a particular disease. NCD will have another set of data that they would like to really mine it, analyze it, and advise or act on it based on the data which is coming up there.
Right. Alka ma'am, I'd come to you now.
Yeah.
Ma'am, can you give us your closing remarks and tell us how this partnership with government agencies and Wish Foundation can be leveraged further? COVID is raging our country, but healthcare is something that we'll keep giving even after COVID goes away. So how can you leverage your partnership, and what would you like to say in your closing remarks?
Yeah, so just to also say something about the continuity of care in the community engagement, people still have their normal essential health service needs. And I think we, through our various systems and digital and remote and distancing, etc., we still try to make sure that continuum of care to the last mile continues. So I just also want to say that, we are very thankful to the central government and the state governments where we work, Assam, Madhya Pradesh, Rajasthan, UP and Delhi. Also to IHW and to our partners, both global and local, I would say bilaterals, corporates and foundations. And I just want to say, for the larger public good, the primary healthcare space is one where as many hands as can join together should join together, because as you said, the problem is huge and it may come back. It hasn't gone away. It's still emerging, going down in some areas. So I would feel that at least as a start, all the agencies who are on this platform and other platforms come together to work on a larger agenda, which is the public primary healthcare space, where WISH is structured very well with the government to actually scale up and take some of these examples to different states, which is also our planning to expand to other states where the need exists.
Right.
Yeah.
Yeah. So,
Yeah,
We have 2 minutes.
yeah.
Shankar wants to say something.
Yeah, I just want to add on the question. No, Rajesh ji has already mentioned all the things. Just to give you one of the example, so WISH created Aam Aadmi Mohalla Clinic COVID dashboard to provide high-level picture on influenza-like illness cases that are being treated at Aam Aadmi Mohalla Clinic, to have an idea the districts in the Delhi, showing high potential incidence of COVID-19. And the last one, which I just want to add, and which is very important for us, as virus doesn't know borders, the digital technology also doesn't know borders.
Anisha, just to complement what Alka ji was mentioning, and the specific perspective of partnering with WISH. So WISH's mandate is to collaborate, and the need within the primary healthcare is so immense that not a single entity would be equipped enough to really serve the purpose. Having said this, WISH is right now working at the national level with NHA, NIU, through NIUs, and we are already there at the national level and looking at a lot of collaboration to happen on that front. The National Digital Health Mission is also vested into the National Health Authority, and we already have a NIU at the national level. With the state governments, we have very structured MOUs around primary healthcare, both on thematic areas, on technical advisory, on specific data analytics and management, at the same time scaling of health and wellness centers. We are very, very clearly collaborating with autonomous entities who are very clear decision makers at the central and the sub-national level. We are also collaborating and reaching out to research and academia, because all this data that we have ultimately a certain phase would provide trends for artificial intelligence and analytics for larger good. And that is where we are really aiming for. And this is a great avenue and opportunity for all of us to come together and create those, I would say, platforms which have integrated,
all the data,
which are collaborative in nature, open in architecture, at the same time are interoperable in terms of design and features. So for us, I think WISH is already geared up to take that challenge, and we're already venturing into it. And we would like to really collaborate with all the people who are really willing to reach out to us, not on the technical side, but also on the grassroots integration. That is really the need of the hour. Rajesh sir, I would request you to kindly add on the partnership element if you have to, sir, please.
So I think, Arish, you have already summed up quite well. And I'm sensitive to the time that Anisha has on limited time. So right. Thank you very much, Anisha.
Thank you, Rajesh ji. Thank you, Alka ma'am. And thank you, Arish ji, for taking us through the remarkable work being done by WISH Foundation. We wish you all the very best to take this collaboration to every state, to every nook and corner of our country. And I would request you to play the video that you have as well, WISH Foundation video, so that everybody can have a look at the work being done by the WISH Foundation.
We work towards improving the quality of and access to primary healthcare services by implementing healthcare models in partnership with the government, civil society and private enterprises, thus exemplifying the public-private partnership model. By identifying promising innovations, demonstrating their impact and scaling up best solutions within the public health system. By making services affordable for communities. By ensuring sustainable and scalable models in partnership with the government to serve populations on a large scale. Through the Health and Wellness Centers, WISH presents a unique proposition of reaching the last mile with a range of primary healthcare services including diagnostics, video-based teleconsultation, and automated drug dispensing.
So we focus on healthcare primarily, and within that we focus on the primary healthcare. The theory of change of wish is that if we strengthen the primary healthcare, it will really address the accessibility part, the availability part, the equity part, and of course the quality of services part there. Primarily we work with the government, so many of these data sets are very confidential in nature, and earlier we were really keeping in the data on someone else's cloud there, our partner's cloud there. As we started learning who is really key and critical to the public health data part, who really have a higher level of integrity, who have a higher level of ethics and maintains that not only in talking but also in the practice part. And during that journey and learning part, we came across AWS. At this point of time, we have a huge data set in Delhi where, on behalf of the government of Delhi, we really manage the famous Aam Aadmi Mohalla Clinic. And we are the custodian of the data on behalf of the government. The data doesn't belong to us, it belongs to the government there. But the highest level of confidentiality and the ethics is our responsibility as an institution. So a huge data set is going to be is being kept at the AWS from the Mohalla Clinic. Similar kind of initiatives are being replicated in other states also for the urban health program, primary health care program there. That will generate a huge data sets there. We work in Rajasthan with the government of Rajasthan in running and managing some of their primary health centers. We have also piloted a tech-enabled automated health and wellness center, which is everything is very automated there. So all these data are human data there, data of health of an individual there. And no better than the AWS could have been the better place for us to really safely and securely place these data sets.
You could see improvements in the rate of immunization for children and care for maternal mothers in a whole range of metrics that we were following with the government.
In a short span of time, Wish
has reached 21.2 million
people through its range of services and aims to reach 100 million by 2027.
My ultimate wish for Wish Foundation is for a healthy India at 80. By the 80th anniversary of our independence, by the year 2027, that everyone in India has access to good quality healthcare. No one suffers, no one loses their livelihood because of lack of access to healthcare.
Sure, ma'am, Mr. Ramashankar ji, Mr. Arish ji, thank you so much for taking us through the wonderful work being done by the Wish Foundation. I'm going to move on in the interest of time and welcome in the next team that we are going to discuss and the project that they've done, which we are going to discuss. We are very happy to have with us the American Indian Foundation team. Their project, Maternal and Newborn Survival Initiative, MANSI, is a community-focused health intervention that addresses India's significant hurdles in accessing quality and affordable healthcare for mothers and newborns at the household level. Now, AIF COVID-19 Relief and Response has directly reached more than 400,000 people across 17 states in India as on the 7th of August. It's such a privilege for me to speak to the pioneers who are doing such rewarding and innovating their approaches as they see unexpected changes on the ground. Please welcome the MANSI team. We have with us Mr. Matthew Joseph, the country director, and Mr. Amit Chatterjee, Mr. Kamlesh Sankhi, and Dr. Swati Jha, Director of Education. Welcome to this this show. Mr. Matthew, I'd like to start with you. Can you share with us how AIF has pivoted during the COVID period and reached out to so many people? What were the initiatives that AIF has undertaken?
Thank you, Anisha, for having us on this show. See, AIF has been working on 4 major areas: education, livelihoods, public health, and leadership development. And for us, when the COVID pandemic hit India back in March, it was relatively easier for us to pivot our work, considering one, we were set up in 2001 in the backdrop of the Gujarat earthquake, where we started our journey. And learning from that, we had worked in almost every pandemic, every calamity or disaster that hit India, including the tsunami or the Uttarakhand floods or the Kerala floods. So the organization was very tuned in to act immediately for such in such situations. So, taking in account the presence that we have across the country and the connections with the governments that we had already had in place, we quickly reached out to the government and asked them what is most important for them. Considering there was a lot of confusion at the time, medical equipment was not available. So we started off by supplying ventilators to many of those COVID centers across many states. And then we took it on ourselves to support the COVID warriors, especially the doctors and nurses and others who are the frontline warriors in this war. And we provided almost 80,000 PPE as on date, and we're sure it's going to reach about at least 100,000 very soon. Around the same time, the situation was developing in different ways that were very concerning. The migrants were held in camps in different cities, and we needed to get to them with rations and with basic protective gear like masks and hygiene kits. So we could reach out to many in Mumbai, Delhi, and Hyderabad, and other places where they're being held. Uh, since we have a large health program that is covering many of the states, we felt it is our duty to protect the frontline workers, the ashas and others who actually go out into the community and meet people. So we made sure that they got protective gear, at least the masks and the face shields and gloves and other basic gear, so that they are safe while making others safe. At the same time, we had already distributed about 6.6 million meals to those who are in need. These were the primary activities that we were doing, and we continue to do that.
All right. Dr. Chatterjee, I'm speaking with Dr. Amit Chatterjee here. Now, ever since the pandemic broke out, has it been a challenge to achieve the SDGs for maternal and child health, which now seem to have taken a backseat because everybody, all resources are focused towards COVID. How is AIS Mansi program addressing this challenge?
Good afternoon, Anisha, and thank you very much for giving me this opportunity to speak here. Let me just give a brief about Mansi first. Mansi stands for Maternal and Newborn Survival Initiative. So we've been working since 2009, especially in areas which are very hard to reach, tribal areas and so on, where healthcare is almost, inaccessible. At present, we cover 4 states, covering almost about 2.3 million population. The states we cover are Jharkhand and Orissa, Andhra Pradesh, and Uttarakhand. And we plan to widen our horizon. Our program, Mansi, is primarily focused on improving, doing the capacity building of the frontline workers or the ASHA workers, right? So because of the in addition to what Matthew has already very lucidly brought out, the work that we have done in COVID, the ASHA workers basically. We build their capacity, and they are frontline workers in providing maternal and child health, as you all are aware. Now, because of the COVID pandemic, what has happened is the ASHA workers have been diverted at least in the first 2-3 months. They have been diverted to doing other duties such as fever surveillance, monitoring, and tracking in the rural areas, and that has caused a lot of the MCH program has taken a backseat. There's been a study done in 132 low developing countries, low income developing countries, in which they say that if the maternal and child health services get reduced by 10%, the number of global neonatal deaths are almost more than 168,000. That means approximately 1/4 of these deaths will happen in India if our maternal and child health services provided by the frontline workers and is reduced by 10%, which is almost like 48,000 neonatal deaths. So that's the level of the how this pandemic has affected us. especially the work that we do. I mean, antenatal checkups are not being done in time. Immunization has suffered, especially in the first couple of months. Now things are slowly evening out. On top of that, there's been an income problem. There's no transportation, and therefore, the public health services are hit. Sometimes the doctors are not there, the staff nurses are not there, and also from a patient perspective or the pregnant lady perspective, she's not been getting adequate nutrition because the supplies, fresh vegetables have been hit. So there's a malnutrition problem. And so these are the problems our frontline workers and our team on the field. We have been working on the field since years now. So we have teams on the field. We have an excellent rapport with all the frontline workers. We have all their telephone numbers and also the numbers of the patients. Or I won't say patients. That's my fault. It's my bad, because pregnant woman is not a patient. So we have the numbers of them, and our frontline workers on the ground, they are called the community mobilizers or the Mansi team workers. They are in constant contact with them. They have been trying to guide them through this crisis, giving them taking them through, arranging for their antenatal checkups. The VHNDs are we cannot have VHNDs these days. VHNDs are the village health and nutrition days, where people get together and the antenatals are done by the auxiliary nurse midwives or the ANMs, or the antenatals are done at the PHCs. However, this is not happening on a regular basis. It's being done in a staggered approach. So our workers are there on ground, trying to facilitate so that the pregnant women do not miss out on their antenatals. That's one thing we are trying to do our level best.
Right.
And also the immunization. Right. So basically, we put it into three buckets, so to speak. First is, creating an enabling environment for the ASHA worker. Now, we want to make them digitally savvy. It's
right.
Very nicely been covered by both Wish Foundation and Dr. Hema Devakar. And we would definitely like to collaborate, learn from them, because, increasing the digital literacy in ASHA workers is one of our key way ahead. In addition to that, we would, we are working with adolescent girls, because we are following a life cycle approach. Adolescent girls will lead to a healthy mother. We are sort of training them on, at least on the phone these days. And we are in constant touch. Our workers are in constant touch. They have specific areas, and they are in constant touch with them whenever they cannot reach out to them in case of containment areas. They are working with them on the phone, and on video messages. Yes, and we are trying to put in software into place where we will probably collaborate with organizations such as Wish and artists in going ahead, and also spreading community awareness about the COVID, and by establishing an IVRS system where the community can reach out to healthcare as and when, if there's any
if they have any questions. Right. Okay. So it seems that there is a little bit of collateral damage, at least as far as reaching out the healthcare and being provided to expectant mothers and the immunization. And let's hope that we get back to normal as soon as possible. Mr. Sangeet, Mr. Matthews also mentioned the migrants and how they face a huge disruption. Going from larger cities back to the villages. So the government says that it has a plan to give them employment in their homes. Could you tell us what AIF has been planning to do for rebuilding the lives of migrant communities and vulnerable populations?
Sure. Thank you, Anisha, for giving AIF this opportunity to share our ideas and what we are doing with this whole forum. So, the migrant community issue is a very unique issue. First, this issue is not a new problem. They have been a sort of an invisible population for a very long time. The good thing about what COVID has done is it has made this problem visible. Now, the second issue is that, when they went back, they were already having a livelihood in city, and now they've gone back to a place where, as it is, there are a lack of livelihoods. That's the first reason why they come to the city. So it's a little complicated on that front. And then also, within the next 2-3 months, we are expecting many of the migrants to come back to the city. So, amidst all this confusion, what we thought is that, we are going to look at a 3-way approach just to organize our thoughts and our plans, where we say the first part deals with helping them survive in the immediate term. The second part deals with helping them revive their livelihoods, which is the medium term. And then when we have engaged with these people over a period of 1 to 1.5 years, how we can help them thrive by giving them upskilling and taking them to the next level in terms of the economic status. Now, the first part is what we have in a way, undertaken, what Matthew just mentioned. The emergency relief was the part, and we are at the stage of right now, the second aspect is reviving. And there are three main pillars under which we are working. The first is a project we have launched called Project Entrepreneur. Prerna, as you know, is inspiration, and our idea is to inspire micro entrepreneurs to revive their livelihoods. And we plan to reach out to about 1 million street vendors. About 70 to 80% of them are migrants, if not even more. I mean, most of them have come from cities and they established their very, very small businesses. They have not been registered for a very long time. There was a regulation that came in 2014 which started giving them legal status, which was not even existent earlier. Second, they have been dealing in cash. Now, as you know, under a COVID context, dealing in cash can be very dangerous in terms of hygiene. For the economics, it's a fundamental source of danger for the street vendor, for the customers, for their family. So in Entrepreneur, we are looking at three pillars, which is digital payments, enabling them to move on to digital payments. Second, getting them registration done, assisting them in that, because that also is a complicated exercise. There's a lot of stakeholder engagement involved. And the third is we are trying to give them working capital access. Fortunately, government has also launched a scheme which we to dovetail with and ensure that that scheme also becomes successful by having more of these street vendors getting the access to the working capital. So that's one program that we are looking at. Second is what we have launched called, it's not a launch, we've been undertaking this as a successful model for a very long time, that when the migrants have gone back to the rural communities, the issue is the employment is not there over there. Right? Now, how do you solve a problem of employment? Because skilling can solve the problem of lack of skills, but how do you solve if employment itself is not there? So we have been creating what we call the TPC, the Training Cum Production Centers, where the candidates get employment and get the ability to create an entrepreneurial model while coming to the training itself. So the the training center also dovetails and kind of doubles up as a production center. And we have done this very successfully in Rewari, where a lot of the women were not even allowed to go to the industries once we had trained them. Because of the kind of a social issue that was existent over there.
So they were doing their own, once they learned, they started doing their own businesses.
Yeah, no, they were allowed to go to the training center, but they were not allowed to go to work. So we converted the training center into a kind of production center. And now they come, we do the, sourcing of
raw materials.
Raw materials as well as, market linkages we undertake. We get the orders, give the candidates. And since they are presenting that, they are going to the training center, the training is getting advanced, they are able to take this whole thing forward. And then once they start earning, their family also becomes open-ended. The reason why we did this, we are doing this now in the migrant affected areas also because industries are not present. So creating these kind of mini, micro entrepreneurial
enterprises
help creation of 1 to 2 jobs while also giving the, entrepreneurial
training
women. So, a little creative kind of mix is what we are undertaking. And the third is the project called Enabler. Enabler is internet-based livelihood rehabilitation, where we are saying that remote employment, we were undertaking remote employment way back in October when the pandemic hadn't even hit. The idea is that remote employment for us was an innovation 6 months back. Today it's mainstream. And people in villages, again, as I said, don't have access to jobs. If we can give them adequate skills for jobs which can be done remotely, they have access to jobs not only in Mumbai, but anywhere in the world. Now, how do you facilitate that? And how do you, create a solution where the problems of the rural population can be solved? And that's where we created tracers, training from remote employment centers, for providing this kind of remote employment and also facilitating it because companies also need facilitation. If they will take remote employees, they also have their own issues of working with the remote employees. So we have kind of become an agency which is bringing together the companies and the candidates.
All right. Right.
space of remote jobs onto the rural level. So that's
Right.
three broad narratives. I mean, there are many more in livelihoods.
Right.
Every city has a new model of livelihood.
Right.
But due to the paucity of time, I'll try to cover these three. So these are the three broad directions which we are taking in terms of our COVID response and trying to rehabilitate the lives of migrants as well as many other affected youth.
All right. Thank you so much, Ms. Sangi. I wanted to check with Dr. Swati Jha about the education program because school closures have really impacted students who do not have access to devices. How is AIS education program planning to ensure that all the gains that you've made over the last decades are not lost?
Thank you and good afternoon, everyone. You see, prior to the pandemic, India was already struggling with the challenge of improving quality of learning, and this disruption is bound to have adverse impact on gains already made, in terms of access and quality. Now, this lockdown and closure of schools has definitely brought about out the stark difference in educational and digital divide across, urban and rural, privileged and non-privileged schools. And this is one of the, biggest challenges that one needs to address. On top of it, India is at the cusp of, demographic dividend. And if we don't address or unlock education in the sense, not in terms of physical, but in terms of reach, then we are going to stare at a demographic disadvantage. So this is the challenge, and this is also an opportunity to make education more inclusive and resilient. And this is what AIF's education programs, which work in remote rural areas with marginalized communities and in under-resourced schools, that we have been striving to do. The moment pandemic started, we went back to our local field teams, did telephonic surveys, and found out the extent of access to digital tools. And we found that hardly 10 to 15% parents had phones, and that too smartphones. Feature phones were there, and in areas there were no internet, nothing, not even a television or anything. So we took that, and on that data we recreated an innovative learning environment where we incorporated both tech and non-tech measures. Our key focus was on two critical things: one, to stop the loss of learning, and second was to ensure continuity of education. So to do this, we leveraged our long-term investment in communities, because by design, AIF's education programs work in geographies, particularly in migration-affected geographies, for a long period. We have been there for 10 to 12 years. And during that period, we have created a lot of social capital, social and human capital. So we leveraged this presence with schools, with communities, with SMCs, parents, children, and also we have created over a period of time a cadre of youth volunteers. And in addition to this, we have been supplementing educational resources by setting up learning resource centers supported by the communities. So we mobilized all these resources, and we came up with an idea that wherever technology can, we started an online access to platform for children so that they can access education. But wherever this was not there, we said, okay, we got these youth volunteers on board, and we started mobile libraries. So it is kind of, it's not a vehicle driven, but it's sort of a a library in a bag on a bicycle, and taken around the village regularly by this youth volunteer. So tech and non-tech measures we took. And second key component, we realized that when government started that, a digital education for children, but since there was no, even teachers needed help, all of a sudden they were expected to
run online classes.
Yeah, online classes. So we went around, we supported teachers in transitioning to online and offline content or classrooms.
Okay.
So this saved a lot of time lag which is taken by the government in planning, training, and implementation. And this way we have reached around to, from April till date, to 95,000 children. And some 3,350 teachers have been trained. So this is continuously being done. One key thing is that we realize that we really need to give these children continuous access to content or unified content. So we are in the process of, having a partnership with India's one of the leading edtech, and they are giving us free licenses, free of cost for 3 years. And this year itself, it will help us to cover nearly 3,000 schools and 300,000 children across.
Right.
So
right. Dr. Jha, thank you so much for taking us through your education initiatives. I'm sorry we're really running tight on time, but I would like to thank Mr. Matthew Joseph, Dr. Amit Chatterjee, Mr. Kamlesh Sankhi, and Dr. Swati Jha of the American Indian Foundation for taking us through the initiatives that your team has undertaken. There is a video also that we'll take a look, but thank you all for sparing the time to come here and talk about your projects.
अभी पहले से बहुत बदलाव आ गया है गांव में। अभी पहचान भी बन गया है कि पहले तो किसी का बहू का नाम से हम लोग को बोलते, लेकिन अभी सैया का नाम से मतलब हम लोग को पहचान हो गया है गांव में। सैया अगर हम इस गांव में नहीं बांधते तो शायद गांव भी नवजात शिशु मृत्यु हो जाता है और माँ भी मृत्यु हो जाती। हमारे गाँव का माँ बच्चे को स्वास्थ्य सेवा दिलवाना हमारा काम है।
बीच रे बुटी गेलना एंते अगर रेत को लगाव की इनका बुटी को रे ये को दूध कालम तो ये एंते ना एंते इनका कलिंग तो की ठीक ये रेत को ले लगाव की
an incredible job of focusing on women and children across the country. This is Team Vedanta for the project Nandghar. Nandghar is committed to the Prime Minister's vision of eradicating child malnutrition, providing education, healthcare, and empowering women with skill development. Nandghars are transformative leap dedicated to benefit rural children and women in India. So let's welcome the Nandghar team. We have Project Head, CEO and of Nandghar, Ms. Ritu Jingo. We have the Head Stakeholder Engagement, Project Nandghar, Dhruvanarayan Mukherjee, and we have Mr. Sweet Mishra, the Head Strategy and Communications, and Mr. Khurram Nayab, Head Operations at Project Nandghar. I'd like to welcome all of you for coming here. Ms. Ritu, I'd like to start with you. Could you tell us about the Nandghar project? How is it changing the landscape of the Anganwadi ecosystem in our country?
So first and foremost, thank you very much for inviting us. I see an illustrious lot which has gone before us. Really commendable work from the IF, Wish Foundation, Mansi, and the others. As far as Nandghar is concerned, we at Vedanta, this was the year 2015. And what we said that, what is it that we must stand for? So I think it's our, chairman's personal vision that how he can contribute to the landscape of women and children. And with that, we said, one program of the Government of India, of ICDS, which really he said, let's collaborate with. And what we did then was, we actually said, let's change the entire landscape and give to government a model where we can actually support them in the delivery system of the Anganwadis. So while we move along today, I mean, Sudeep will actually take you down and through that whole journey of what really is a Nandghar. It actually is transformational to know that we look at them as small units of where people come to take khichdi, right? But what we've done is created transformational services of health, education, nutrition being a very important part of holistic healthcare. And furthermore, the Anganwadi, traditional Anganwadi in India is, closes at 2 o'clock. But what we said, let us involve the women also. And so we started it as a skilling center. So women who had surplus time actually became economically empowered. And today we are touching the lives of many. So as we go along, we will, but before we start off from a Vedanta standpoint, and a lot of people have talked about the COVID scenario, right? There's a lot of contribution, I think, that each one has done, and in our own little humble way, whatever we could do. I think Mr. Anil Agarwal, our chairman, was one of the first few industrialists who came forward and said, we stand by the nation and we will do whatever it takes to support. I think there was a large conversation right now about migrant workers, right? I think it was amongst the first few voices that we said, how is it that every person who walks out must actually get food on the table? I think Khurram here has done a tremendous job where 15 lakh meals were actually supported by us to all these daily wage earners and migrant labor during that time. We have actually an audio film. Do you think we can just run that film?
Ma'am, we'll run that film after we've heard from your teammates. So I'll just hand it over to Mr. Khurram Nayak. Sir, could you tell us about these meals that were given to the workers? Could you tell us about this initiative, especially in the COVID times?
Thank you, Anisha. Thank you very much. Well, as part of the entire Vedanta group, what we had done is we reached out to the migrant laborers. As a chairman said, it was his vision that no migrant labor and no daily wages should go hungry in these COVID times. And also, since they were traversing somewhere traversing around 1,000 kilometers, some 2,000 kilometers, somewhere 1,500 kilometers. So on their train journey or on their journey by the road also, they should have these meals to take care of themselves as well. And along with the meals, so what we did was, along with the meals, we also did, the important thing was the slippers. Like we provided them with a pair of slippers also, because we did see that some of these migrant laborers were walking barefooted, and it was really, the chairman was really moved to see these pictures on the media, and he advised us to start a project like this. So so we reached out to these migrant laborers across the 4 cities of Bombay, then we had Patna, Delhi, and Gujarat, and in Ahmedabad in Gujarat. So so that was it. So something around 15 lakh meals were provided across to these daily wages over a period of 2 months.
Let me add to that. Let me add to that. You know what we did, Apana? We didn't restrict it to a particular state only. We went across Bihar, we went across to Mumbai, we went across to Delhi, and I think one more additional thing that I was delighted that during this time we actually also fed stray animals as we go along. I mean, we did Mumbai, Pune, Jaipur, Delhi, all across. I mean, as much as we could do. That was one part. In totality, we sort of have, I think it's a data point, but more importantly that, approximately 200 crore has been spent just to make sure that during COVID times that, we can contribute to healthcare. I think more importantly, in Rajasthan, in Chhattisgarh, we actually have created isolation wards. We have contributed. We have in Raipur, Balco actually has a medical hospital, the Cancer Research Hospital.
Right.
Yeah. So we've converted that into a place where is isolation, but also cure. So,
ma'am, you have a PPT that you want to share with us, showing your
yes, Anisha.
project?
Can we?
Sure.
Can
So
I share
you can
the
hand
PPT?
over that. So I can request Sudeep if you can run us through the presentation, please.
Sudeep, over to you. Is everyone able to see the slides?
Sure.
Yes, please go ahead.
Yes, thank you so much, Khurram. Good afternoon, everyone. What I'll quickly do is in next 5 minutes, I'll take you through to our journey of Nandghars, where what we have set out to do is, change the landscape of Anganwadis in India. So as you know, there are 14 lakh Anganwadis across India. What we said, we want to present a model to the country that how the Anganwadis can be best operated, and both in terms of infrastructure and services can best leverage the existing Anganwadi ecosystem of India to make the difference in the lives of women and child. So what we do, Khurram, if you can roll it to the next slide, we built up this really nice structure, sort of in look and feel comparative to a private preschool, which sort of breaks the taboo of an Anganwadi in the rural landscape. And if you look at the kind of partnership that we had, we got into an MOU with the Ministry of Women and Child Development. And we said as Vedanta, we want to do 4,000 such Nandghars across 11 states in India. And these will all be aligned to the national priorities, which are Startup India, the Swachh Bharat, the Beti Bachao, Beti Padhao. And what essentially we do is, if you look at, we have a state-of-the-art facility, which hosts solar panels for 24/7 electricity. We have clean drinking water. We have water purifiers. We have a nice infrastructure in terms of building with artistic paintings and using building as learning aids. In terms of services, it caters to 4 dimensions. One is learning, and we have put up a smart television inside each Anganwadi, which caters to the e-learning part of it. From a health perspective, we have, while we continue to strengthen the Ashas and the ANMs attending the Anganwadi, we have given 1 mobile health van with an MBBS doctor and a paramedic to each cluster of 25 Nandghars. For the nutrition, our aim is to have hot, nutritious cooked meal at the desk of each child. And in the second half, what we're using this infrastructure is for the skills training. So a batch of 30 women sort of attends a training course and to get some incremental income by after attending that skill development course. So overall impact with 4,000 Nandghars, we are looking to reach out directly to 1.6 lakh children, 1.2 lakh women. And whereas from a community perspective, the total reach would be around 4 million community members. Happy to share that we already are at a milestone of 1,450 Nandghars already. So we already have a presence in 7 Nandghars. Khurram, if you can roll to the next slide.
It's already there.
Speaks about our existing presence. So we are already reaching out to more than 50,000 children and 40,000 women as we speak. And our target is to build 2,500 Nandghars by end of this financial year and reaching to 4,000 target by September. So having said that, Khurram, if you can roll to the next slide, we can look at how we have responded exactly, because Anganwadis are the most affected ecosystem with this COVID times. How we have responded to the this unprecedented situation and how we have delivered our services to the Nandghar. Khurram, over to you.
Thank you, Sudeep. Thank you. It was so just going forward. These are the 4 key thematic areas like education, health, and nutrition, and skills. In fact, some of the organizations which have joined us also today as well, they also know about a lot of things, and some of them we have also reached out to them for various requests for proposals on these aspects as well. So just wanted to tell you on the education front, as Sudeep has pointed out, that we teach the education through the e-learning, through the smart TVs which has been provided to each of the Nandghars. So that is it. In the COVID times, what we did was since these Nandghars and the Anganwadi system was closed by the government during the lockdown, so we reached out to these the homes of these children, provided them with e-content, to train the parents on how to teach the children on e-content, and through their mobiles they were able to teach the children on the courses, so that the child does not lack when the Anganwadi is open after the lockdown itself. Okay, so that was on the education front. On the health front, our OPD vans, like there are something around 12 OPD vans running across the Nandghars, and another 8 to 10 vans running across the different business units like Kane, Zinc, and other business units also. So something around more than 20 health vans. And most of these vans were converted into ambulances for the COVID patients. So we did partner with the various departments, various ministries of health, and various state governments to provide them with the mobile health vans, which we were running to use as COVID vans for the help of COVID. Under the nutrition front, if you see later, like we do have the pictures in the snapshots, we did some kitchen garden across our Nandghars, and provided these kitchen gardens yielded some good customized foods for the villages, for the community, for the children also. Apart from that, the take-home rations which was to be delivered at the Nandghars is now delivered at the respective homes of these children itself. So that's what it is, and we are partnering with Manrega scheme to develop the kitchen gardens. Coming to scales, as Sudeep has pointed out, that in the second half of the Nandghar, when the preschool education is over, in order to optimally utilize the space, we did train the women into skill and entrepreneurship development. And you will be happy to know that in the next slide that something around 50,000 women were targeted through 25,000 women were targeted through this, and we these women developed masks, sanitizers, which was distributed by the government to the needy and to the children itself. Okay, moving to the next slide. These are some of the initiatives which I just explained on the online training for the children. Then children e-content was provided, like we did partner with the UNICEF to roll out this content across Rajasthan, across 60,000 Anganwadi centers of Rajasthan, touching 12 lakh children there. Then we had a distribution of workbooks and slates so that children at home do not really bother the parents while they start their own learning, do their own learning. I had talked about the mobile health vans being used as the OPD as ambulances. Then we did have some vaccination checkups across these networks. Going forward, as I said, like something around 70,000 masks were distributed across various states where we are operational. Then take-home rations to each and every beneficiary was there. We did provide customized food to the kitchen gardens, and you would be happy to. I would be happy to share that the Minister of Women and Child Development, Srimati Smriti Irani, also tweeted on her tweet or when we distributed 5,000 masks in a meeting itself. So these are certain testimonials from her. These are some of the snapshots. The capacity building of Anganwadi workers across these 25 for these Nandghars on training them on kitchen gardens. Then the mobile health vans operating. Have a celebration of various national days also. Then we have the early childhood education being taught at the home. Then we do have some communication materials there. So we did celebrate the Environment Day as well, like during the lockdown as well. Going forward. Thank you very much for the time. Now, would request the organizers to please start the video. It's just I think a minute of video. If you can do this.
माना इम्तिहान की घड़ी है, चुनौतियां लेकर जिंदगी खड़ी है, जिंदगी खड़ी है। जरूरतों के मतलब बदलते जाएंगे, पर देश की जरूरतों में हम हर पल साथ निभाएंगे, साथ निभाएंगे, हम हर पल साथ निभाएंगे। ये रथ कोशिशों के निकलते रहेंगे, उम्मीद उम्मीदों के चूल्हे जलते रहेंगे। है एहसास हमको बहुत कुछ है करना, अभी तो है आशा में और रंग भरना। मुश्किलों के आगे दिए हम जलाएंगे, दिए हम जलाएंगे। जरूरतों के मतलब बदलते जाएंगे, पर देश की जरूरतों में हम हर पल साथ निभाएंगे, साथ निभाएंगे। पर देश की जरूरतों में हम हर पल साथ निभाएंगे, हम हर पल साथ निभाएंगे।
वेदांता, देश की जरूरतों के लिए।
Open for any question answers. Thank you very much.
Right. Congratulations to the Nankar team for the exceptional work being done by them. Mr. Mukherjee, very quickly, if you can tell us what's next, the next plan that you have for Project Nankar.
See, we have, as per the MOU that we have signed with Government of India, we are set to develop 4,000 Anganwadis across 11 states of the country. So now we are standing at 1452, and we, as Sudeep mentioned, we will close the financial year with 2,500, and by September 21, we are targeting to develop 4,000 Anganwadis. Now, the MOU that we have signed, it specifically talks of infrastructure development, but we realize that just by developing infrastructure won't serve the purpose. So we have rolled out these programs of education, health, nutrition, and skill development from our innovative approach, you can say, and that will ensure that the infrastructure that is being created by the program is actually being optimally utilized for community development and development of women and children in the region.
All right. So here's wishing you all the best. Let's hope you will hit the target and at the assigned time. And here's wishing Project Nankar all the very best. We're now going to move on and talk about our next project and the next team that will be in the spotlight. And this is the VRSC, the Bhanumati Ramesh Shah Charitable Trust, and Welcome Cure. Their project is Health and Immunity for our COVID warriors and citizens. VRSC Trust has sponsored and donated immunity medicines along with Doctors Care Program via telemedicine as recommended by the Government of India and the Ministry of Ayush. The VRSC Trust, along with other organizations like Lion Club, Giants Group, and other NGOs, and Welcome Cure, distributed thousands of medicine kits and telemedicine programs of thousands of families of policemen, traffic police, fruit and vegetable vendors, firefighters, etc. So let's welcome the VRSC team. We have Snehal Shah, Ankit Shah, Mr. Neil Dodia, Mr. Jawahar Shah, Nidhi Desai, and Puneet Desai, who are joining us today. And welcome to all of you, and thank you so much for taking the time to join us. It's really heartening to see the good work being done by so many organizations here. I wanted to start with Mr. Snehal Shah. What triggered you to pledge for this project? What was the thought process?
Yes, madam. Thank you. Thank you so much for giving me a chance to speak in this excellent forum. More importantly, it's an inspiration center to me for sharing my views in this forum. Though I have been a beneficiary of alternative medicines myself, me and my family, when we saw that during this COVID-19 breakout, there was a massive issue in accessing a doctor for a mere consultation. And when we saw that no doctor was attending his own clinic, possibly out of fear of they themselves being possibly exposed to this risk, it is at this time when we also learned that the government of India, through its Ministry of Ayush, had launched an advisory that recommended citizens of our country to take Ayurvedic, homeopathic, and alternative therapy products as an immunity booster, especially since there was no cure for coronavirus then, and as we all know, there is no cure even today as of date itself.
Yes. Yes.
Yeah. And so at that point of time, and after considering this abnormal situation of such a huge natural calamity, we as a public charitable trust whose objects have always focused on health and education as priority sectors, and of course with us also being the beneficiary of alternative medicines, and more importantly, having known this organization, Welcome Cure, which is well known to provide healthcare solutions through its online portal, it gave us an impetus not only to support the cause, but also to strongly pledge to the best of our abilities and to do whatever best during this pandemic. Yeah.
Right. So I'll come to you, Mr. Desai. Can you tell us what were the challenges that you faced? And you were executing this project, like Mr. Shah has mentioned, that alternative medicines which are not mainstream, that even regular doctors are not available. How did you go about executing this project?
Hi, Anisha, and a very, very good evening to all the members on this forum. Very great to hear the great initiatives done by all of you in the last 3-4 months. Coming to your question, Anisha, it was definitely a situation which we've not been in before. But the good part is, we being a out and out digitally empowered and digitally focused organization, there were two elements to this entire project. One was providing a large team of doctors to people anywhere in the country for their healthcare needs, and giving them the right advice because they were very, very difficult for them to step out. So while we had a lot of doctors, almost 100 doctors set up, and via our telemedicine platform reach out to patients not just in India but over 36 countries, while they used to provide a lot of solutions via voice, video and text, the biggest challenge for us was that now that these doctors had to use that telemedicine platform from their own homes, so we had to ensure that the best technology, the best internet connections, and all of it reached out to all of them in a matter of very quick time, so that the patients who are already on our treatment programs, and the spike that we were going to see because of the COVID pandemic of patients and the beneficiaries that we had to honor because of the pledge of BRSC Trust to us. So what we did was we ensured that we immediately kind of rolled out these tools, entire technological support to our doctors. So nearly about, I would say more than about 60 to 70 doctors made sure that they all did nearly anywhere from about 70 to 100 plus consults each day.
Okay.
Was one. Coming to medication part of it, that was something that needed a lot of physical presence. We had to come up with solutions where we could produce thousands and thousands of immunity kits, like Mr. Snehal Shah said, that the Ministry of Ayush via recommended homeopathic Ayurvedic medicines. So we've been a pioneer. We've serviced more than about 2 million patients in the past. But what happened here was, in a small span of about 3 to 4 months, we had to cater the same amount of people that we did in the last so many years in that span. And what we did was, like I heard many people in the previous forum, that there was a lot of unemployment also that was there. And we that this unemployment, which was a problem for many, we converted into an opportunity, and we spread the word through various networks that there was a availability of a lot of work for you all, because homeopathy medicines, Ayurvedic medicines, these are things which basically require a lot of human intervention and just good manufacturing practices to make sure that they're all packed in a great format. And we were able to create resources of hundreds of people, increasing day by day, packing these high quality immunity medicines. And once that happened, the good part was in a very collaborative format, where BRSC Trust also had a lot of other, NGOs that were tied up with them, who were working in a closed group, and we used them as a distribution network. So rollout was very easy for us. While we took care of the back end, the front end was also taken care of. So that was how we overcame all our challenges.
All right. So let me go to Mr. Ankit Shah, trustee of the BRSC Trust. Mr. Shah, who do you think, as part of the COVID warriors, were you able to make the maximum impact on? Was it police? Was it doctor? Was it vendors? Where did you see the maximum impact?
Mute. I think it's the mute. I think the mute is.
Mr. Shah, you'll have to unmute yourself.
Yeah, you have to unmute.
Yes.
Hello, everyone.
Yeah.
Yes, please go ahead, Mr. Shah. Yes, please go ahead.
Hello, everyone. I second what a managing trustee just apprised this forum. So during this COVID-19 pandemic, the most vulnerable people were the police force, the traffic police, the doctors, the paramedical staff, and the municipal workers. So these people had to literally be on their toes just to protect us. We were very happy to serve them, and as per our records, they are the largest beneficiaries of Welcome Cure Immunity Kits, more importantly coupled with 3 free consultations from doctors appointed by them, thereby every person consulting them online. Apart from that, we catered distribution of immunity kits to various police stations across Mumbai and its outskirts, and also to paramedical staff, traffic police, firemen, and these kind of people. Hence, we were able to make an impact during these last 4 months. Thank you so much.
All right. Ms. Ekta, I'll come to you. How does it feel to execute such a program on a huge scale, and what's the plan ahead? What lies in the journey ahead? As we all know that, COVID is not going to be here for a short time. It could be an extended guest, so as to speak.
Yeah. First of all, I would like to thank you all for having me here. It's a great pleasure. In fact, it has always been very motivating for us, and seeing such great response has further motivated us to give our best. Well, our immediate future plan has always been to support our warriors, because if our warriors are safe, citizens are safe. So we'll keep our help extended towards our frontline warriors in all possible ways. Apart from that, we see that this new COVID pandemic has led a lot of unemployment across the globe. So we would like to upgrade the skill amongst people by doing some good amount of work in digital education. So as digital education is the future, which can help grow skills amongst people, so that will ultimately help grow employment. So to sum up, we would keep doing the good work in health and medicine and extend our support towards digital education. So that is we are looking forward for that. Thank you so much.
Right. That's great. Mrs. Sayal Shah, I'll come to you for the last word. In this COVID time, sir, do you think the alternative cures have their own place? Because, people are skeptical. There is no cure. But, some people are better off and some people are very badly affected. Do you think this could be a plausible way to, to contain the kind of widespread spread we are seeing of the COVID problem?
Undoubtedly, I would say it is absolutely beyond any iota of doubt. Frankly speaking, yesterday our Prime Minister, while addressing this Independence Day speech itself, has made it absolutely and undoubtedly clear that ultimately the way forward for this country is digitization. So I believe telemedicines, which is basically, of course, ultimately I would say that pioneers are welcome cure for that purpose. We have not to discount what they have started on with 5 years back, and I've been dealing with this company for the last 5 years, and I've known about this brand Welcome Cure since last 5 years. And now when we received a formal request basically from IG Police Shri Krishna Prasad ji, and when we came to learn from him at his level that Welcome Cure happened to be one of the lead players in providing homeopathic medicines through the telemedicine route, and further that he also requested us to provide him and his entire police force in Maharashtra to the extent of 3 lakh kits. It became almost very much, a challenging task for all of us here at our Bhanumati Ramesha Charitable Trust, because it's a trust in the name of my mother, which really puts me and my entire family in top gear to serve in the interest of humanity and and our countrymen as such. And as such, basically, we felt as a trust, of course, it's all our proprietary funds basically, which we have deployed at this point of time. And we look forward to making it bigger and bigger, of course, with the help And when this such a request came from the IG police of the entire Maharashtra state, we felt that we alone will not be able to cater to this
demand.
To this demand and the requirement as to how do we serve. More importantly, then we then took help of various NGOs like Lions Club, Giants Group, Samarpan, Global Health Foundation. Global Health Foundation has also now joined us with another cause by providing certain Dabur kits. So that way, it is really now this entire drive towards making it happen and being a dream come true for us for times to come. We look forward for making it bigger and bigger and bigger. And I'm very sure and absolutely sure. I tell you, when the requirement of the Maharashtra police got fulfilled, along with the help of these NGOs, which I just named, has really made a tremendous impact. I would say tremendous beyond any stretch of imagination that we could serve. And today, when I look upon and ask them, they still call us. Is there any other work? Is there any other work to do? Is there any work? So this gives us a sort of an encouragement to our trust and our entire trustees and entire board to really do something big. And we look forward to making it happen. And I genuinely tell you, telemedicines, doctors' consultation, and working online through companies like Welcome Cure is the only way forward. I would say it's the only way forward. I personally feel so.
All right.
That's the that's the conclusion which I draw basically.
All right. Here's wishing BRSE Trust and Welcome Cure all the very best for the days ahead. The work being done by you is phenomenal. You have reached so many police personnel in Maharashtra. It's really very commendable. And here's wishing you all the very best in the days ahead. Here's a quick video about the work being done by both organizations.
मैं कैप्टन आर तमिल सेल्वन बीजेपी एमएलए साइन कुलीवाड़ा मतदार संघ मुंबई सिटी। तकलीफ ऐसा है, किसी एरिया में किसी का घर का अंदर कोई फैमिली मेंबर को वायरस पकड़ लिया, पॉजिटिव आ गया, बाकी लोग डर रहे हैं। कोरोना पॉजिटिव है, उनका सरकार की तरफ से बीएमसी की तरफ से उनका जो भी ट्रीटमेंट करेंगे। किसी को नहीं आया, उनके लिए ये दवाई आर्सेनिक एल्बम 30 बोल की एक होम्योपैथी का दवा है। ये दवा खाने से जो पर्सन खाने के बाद उनका इम्यूनिटी पावर बढ़ता है। ये डोज आप लेने के बाद आपका फर्क मालूम पड़ेगा। ये मेरा खुद का खर्चा से सेंट्रल गवर्नमेंट अप्रूवल आयुष मंत्रालय का अप्रूवल दवा है।
To control the spreading of this virus through social transmission, the necessary steps were taken by government, but unfortunately it was not sufficient. I would also like to suggest the people that please have this arsenic album 30 to protect you from corona.
I am taking homeopathic medicine arsenic album 30 as an immunity booster. Nowadays many people are also started taking this medicine and the result is very good. The spread of virus has also decreased in many areas thanks to homeopathic medicine.
This is Dr. Selvan. I am really happy that cases in Dharavi reduced. Hopefully, BMC will look in this and change Dharavi from contaminated zone. Now, no one can blame Dharavikars that you are from contaminated zone. I must congratulate my fellow doctors, police officials, health workers and social workers who work day and night for Dharavi. Till now, we have distributed this medicine more than 1 lakh people. Not only my team, many NGOs like Arzu Foundations and politicians were distributed this medicine. I wanted to specify that whoever taken Arsenicum album 30 gave wonderful result. So please continue this medicine at least for 6 months till corona problems get
Congratulations to the VRSC Trust as well as Welcome Cure. Amazing work being done by all of you. Mr. Snail Shah, Mr. Ankit Shah, Mr. Puneet Desai and Niti Desai. Thank you so much. Of course, Ms. Ekta Shah also. Thank you so much for taking us through the good work being done by you. Congratulations and all the best for the days ahead.
Thank you so much.
Thank you.
Thanks a ton. Thanks a ton.
Thank you. Thank you.
We'll now move on to the last team that we have with us and the project that we're going to focus on. Please welcome Team Mantra for Services. The name of the project that we're going to focus on is COVID-19 Emergency Response. Mantra for Change and Surya Foundation have formed a collaboration and started working on a two-pronged approach. On one side, they were supporting the needy with food and ration kits, and in parallel, they were supporting frontline warriors. Please welcome team members of Mantra for Services. We have Mr. Puneet, COVID-19 Emergency Response Head of Mantra for Change and the Surya Foundation. And of course, the project lead, Sarvana Surya, COVID-19 Emergency Response Lead. We've got Santosh More, the co-founder of Mantra for Change, also with us. Welcome to all of you, and thank you so much for taking the time to come and talk about the project that you've undertaken. So let me start with you, Mr. Santosh More. How did you manage to move around during the lockdown? Initially it was very, very strict, and we saw that when all work came to a halt, people didn't have income, they didn't have food, they were in hard times. So how did you manage to move around during the lockdown and help these needy people?
Thank you so much, Anisha, for having us over here. And I would just say that, in fact, how this entire thing started was again because Mantra Social Services, or Mantra for Change as we call it, it's an organization working in the field of education. So we work largely with the communities across different cities, different places. So one of the things that happened during the crisis was because many of our children come from the families which are not from that particular place. They are migrants. They started facing the issues, and that's where we realized the issue that was going to come, and that was already looming hard on our faces. So we, without wasting our time, we started connecting with the health ministry here in Karnataka, and the Rapid Action Squad was formed, which I think Puneet and Sarvana will speak about in detail. But whatever we did, one important thing we realized was that this is a time probably to work with the government and work with the government at scale. And that's where over a period of time, entire city became our, I would say, became our area of intervention. And we were able to reach out to many migrants across the city.
All right. So I'll come to the other two partners in this project with you, which is Sarvana and we have Puneet. Yes, sorry, Sarvana and Puneet with us. So tell us about your experience, and did you also work along with the government to reach as many people as you could?
Yeah, hi Anisha,
Yes,
good evening.
In fact, Puneet and Sarvana will be able to talk more about that. Puneet, go ahead.
Yeah, hi Anisha, good evening. So I've been hearing about all the other panelists speak, and then it's really a great work to see happening across Pan India about the COVID-19 response. I'm sorry we have to wear masks because we are at the office and volunteers are around. So the thing is, we are a set of team of volunteers who started working from the day one of lockdown, and it was a very big challenge for us to move around, even for a small food distribution, because there were like barricades set up across. Police used to check, rigorous. People who did not have valid IDs or movement passes, they used to be definitely their vehicles used to be seized. It was a challenge for us. So that is when we realized that we should find a way or solution to help people. And then we became the part of system itself. And that at that point of time, there was this Corona Warrior Squad that was called for by an eminent IAS officer, which was set up from the Department of Information and Public Relations, where we became the volunteers for that particular squad. And they issued passes to us, and that is how it enabled us to move across the city. So I mean, it's not just across the city. In fact, we have traveled across the state during this phase 1 and phase 2 of lockdown. That was I mean, we saw stranded migrants where food was not provided to them at time, and we also saw hospitals lacking basic PPE equipments, and there were many primary health centers also where they had requested for mask, sanitizers, gloves, and also initially on one end we parallelly started helping people with by providing them food, and on the other end we started working to support our frontline workers also. So I mean, this is a pandemic, and there is no defined timeline as a program as such. Okay, you started this point of time and you ended this point. So every moment or every time there are new guidelines issued by government. There are new policies. So initially the problem was with the migrant crisis and providing of food to the stranded people. But once this lockdown was lifted, and when migrants went back to their hometown, the cases started increasing further. And then right now we are focusing on supporting our frontline warriors, doctors, hospitals, and our focus is mostly towards government general hospitals across.
Right. So Puneet, how are you helping frontline warriors, the doctors and nurses? They're really swamped with work now because the cases are spiraling.
Right. So if you could give me 3 minutes of time, I'm going to share a PPT quickly, so that 1 second, so that this will give you a broad overview of the work that we have done. Can you see the PPT?
I can only see a black screen. Yeah, it's started now. Yes.
Yes. Okay. So I mean, this is the work that we have done. I mean, I'm just summarizing the work that we have done so far. So these are our partners like Mantra and Surya Foundation is where we started our work from the day one, and of course we have done it through Government of Karnataka, and Indian Red Cross Society also have other partners. So we followed a two-pronged strategy. One is supporting our frontline warriors and also supporting. I mean, when I say frontline warriors, it's a medical personnel and then stranded migrant workers also. So we were a team of 23 volunteers in the beginning, where we were enabled to move across Bangalore, and these are the activities that we have done, supporting the vulnerable, animal care. In fact, there were many stray dogs also which was devoid of the basic food, and then we started collaborating with many animal health organizations and started helping these animals. So, and also we work with the frontline workers, that is health department basically. So this is the work where we sent around 3,000 migrants to their native places, and one in each train will carry around 1,500, and we could fully support 2 trains with 3,000 migrants. And yeah, these were the ID cards and the passes that were issued for us for our smooth movement, and this is another pass which enabled us to move across Karnataka. And yeah, these are the few pictures where we have supported food and ration kits to a lot of migrants, and yeah, stray animals. And we supported primary health centers. We provided protective health, personal protective equipment, PPE kits, N95 masks, hand sanitizers, surgical masks also. And another thing is, initial days what happened is there was quarantine. When I say quarantine, it's for people who are coming from other states, or sometimes inter-district movement also. When they were found symptomatic, there was quarantine, and we have set up many quarantine centers also. Quarantine or isolation centers in association with government. Government used to give us space, and then we used to set up the infrastructure there. And we also set up a COVID-19 testing kiosk, and you can see the minister and the member of parliament there. So we also traveled to Belgaum, which was 500 kilometers away from Bangalore. We realized that our friend in the frontline warriors there are again hospitals, primary health centers, and police personnel and all. But we also decided that we had to support the critical agency, that is
A corona warrior and his team are helping the needy at the time of crisis. He is footing bills for medicines and other essentials for the needy. He also delivers food to people across Karnataka, and that too in his own vehicle as well. Interestingly, Sarvana has also helped donate the much needed PPE or personal protective equipment kits to health workers who are fighting on the front lines against the dreaded coronavirus.